I felt it.
You could feel it all, right? You felt that release?
Yeah.
Dude, that was amazing release too. You felt that, right?
You felt it too,
Oh
right?
my God, you completely released.
Wow.
Yeah, a pretty cool experience, huh?
Man.
I love it when we get the man. So right now, Ralph, what we're going to do is I want to replicate what we did on that side to this side, okay? So we're going to bring that arm back. Wow, you already see it, right? So I'm going to hold, actually. Do me a favor, I'm going to put, can you fit it right there?
I had the tear in my
the tear. So I'm going to hold that up. You feel that?
Okay. Yeah,
good.
perfect,
So right now, I'm going to put that over because we don't have a stable shoulder, guys. That's why if you see this, you can see how it's already rounding forward more. So we're going to support it, and then we're going to get in and find our anatomy. Always palpate. There we go. There's our clavicle. We're going to do a little bit of right there. Good. And now you can hear it. So when I hold this longer, what I'm doing when I'm holding it is I'm really creating neurovascularization. And I think you could feel it, right? It's bursting. And then I move it over. You can hear it. So this side right now is way more adhered because it's having to support itself because it's unstable from the tear in the supraspinatus. And I remember we were talking about possibly having one of our providers doing the PRP, remember?
Right.
We'll still have to schedule that because we got to regenerate that. Otherwise, it's just going to get worse.
Those were cells, right?
That's where we're going to take your own plasma and basically we'll have it with special technique to centrifuge. We use an anticoagulant there. We actually use LED lights to stimulate the cytokines, the growth factors, before the providers put it in. It's a really cool process, and I know we'll be able to get some improvement in your labrum and your supraspinatus, because I remember now the MRIs.
Right.
So what I want to do now is I'm going to get in here. We're going to be a little less aggressive on the stretch on this technique, and what I'm going to do more of is I'm going to do more, of the fascia. You feel that? Yeah, I can hear it. Yeah, it's more fibrous here. I'm just going to hold.
So this is breaking up.
The fibrous tissue. So you remember what kidney stones, no longer is it common to do the surgeries. They use a procedure called lithotripsy. And lithotripsy is using a acoustic wave, a shock wave. Just like this, just a higher and breaking up the stones to pass through. So unless it's like a really big, like staghorn they call them, like you actually usually operate now. And I think they even try on the staghorns the first attempt to see if we could break it free.
So the machine is powerful.
It's very powerful. It's the same thing we're using here, same technology, except there it's a little bit stronger of a wave. So they use you under, I think, twilight sedation, probably propofol. Good. Wow. And then you can even see how red everything is, guys, is because that's the neurovascularization. That's us getting the blood flow to the area. I'm actually going to go a little different too. Oh, wow. I could feel the compensation in that out there in bicep junction. So I'm going to come in and work the whole area while we don't have gravity. And I'm going to support it. And then what we'll do is I'm going to have you sit up so we could work this whole shoulder girdle, okay? Ralph, what was your experience with, remember he ended up doing therapy for a motorcycle accident elsewhere, and I did how many treatments on you, 2 or 3?
Yeah.
Made it how much better?
It's like 100.
It was, the difference is amazing.
Yeah.
I felt bad he wasn't with us the whole time.
Yeah.
But either way, we fix it. And then when I'm moving more, I'm doing more of like just trying to use the instrument more as if it's like a Graston tool and kind of get in between the junctions and really break up some of the fibrotic tissue. Usually wherever we have transitions between muscles at the muscle junctions, like here's your pec minor, there's pec major. I like working the junctions. Here's the subclavian, here's pec minor. Where the junctions are is where I like working.
Good.
Awesome. Now, what I'm going to do is actually come in If you don't mind handing that over for a second, and then coming in, and I'm going to hold the arm so you don't have to, and do more of that connective fascial work. Just like that. Good. 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 Wow, yeah, I'm following that. That's good. Good. Good job. Right there. Right there. Yep. Right there. There it goes. There it goes. Good. There it goes. Good. Do that belly breathing for me. That's how we get it to free even more. Belly breathe. Good. So here I modified the technique a little because obviously everybody's a little different, especially if we have instability in that shoulder girdle. Good. Right there. Breathe with that belly. Good job. Good. All right, good. Now, let's bring that arm up. Good. Keep it straight. Good. Let's just test the pec. Hold it right there. I'm going to come across. Nice. Not bad. We got our objective. Wow. I could feel how fibrous.
Right.
Wow. Okay. Let's fix this for you. All right. Let's see. What I want to do is have you comfortable for a sec. So let's just put the arm like that first.
Okay.
Thank you for holding that. And now let's get over in this position. And I'm going to basically use the equipment because I don't know if the camera can see it, but you've got all this fibrous tissue that's been supporting since you have that tear here. Your deltoid has been over supportive and you've got fibrous tissue in there. So let's come in and use this acoustic wave, shock wave, pressure wave, whatever you want to call it, to take something that's old and create neurovascularization. And that way, if we do come in with the plasma, the platelet-rich plasma, we'll get a better objective when our providers over here at I'm Wellness repair this shoulder as a team. Good. Now remember, if we went somewhere, they're going to want to do a shoulder surgery. And then shoulder surgery is not horrible, it's the rehabbing after that we have to be so regiment with, otherwise the chance of the frozen shoulder is kind of high. If we can regenerate at all possible, let's do that. And I remember looking at your MRI specifically, it wasn't a complete full thickness tear, we had a partial, and then we had labral, internal. You're a great candidate. Good. Now you can see how red everything is now. Now what I want to do is come back and try to smooth out that tissue. There it is.
Right on.
Yep, I can feel it too, buddy. That's what I'm doing. So actually this is what you call, in fascial distortion model, our herniated trigger point. You can feel it right there. So I'm going to come in and
Wow.
It's the one good thing about that one technique. If I teach it to you, we speak the same language. So there's like 7 ways the connective tissue distort. And then once we learn those 7, we could speak the same language. Good. Good. Right there. Another herniated trigger point. You can see it.
You get right on it.
That's what I say. We got to be a sniper.
Yeah.
Good. Awesome. Beautiful. Now. Great. Good. All right. Now. All right, Ralph. What I want to do now is I want you to come on up. Sit up for me. You got it? I got you, buddy. Let me grab that tool. Good. We got you.
Got it.
Awesome. Okay. Let's take a look at this shoulder. All right. How you feel? First of all, how you feel?
Oh, feels fantastic.
How's your shoulders? I worked that shoulder girdle. Feels pretty good, right? Yeah, we
Feel
did
relaxed.
all in here. Well, that's a lot. Everything's pulling usually. And then when everything pulls like this, remember, everybody says they feel their tension here. There's a reason. Over here we have what's called the sympathetic stellate ganglion. It's a group of nerves. Whenever you have a group of nerves, it's a ganglion, you know? So right over here, the ganglions, you know? So the gang, I like that. The gang of the ganglion over in the sympathetic here. So what happens is you feel all this tension because the nerves are just firing constantly.
Oh, yeah.
So I'm going to actually, by releasing the chest, we're helping release the tension here. So you should feel a lot more peaceful. I want to see, here you have, so over here we have what's called the horizon sign. So we know that we had a sprain to the acromioclavicular joint, the AC joint, and I could feel it. I remember we talked about this. If I saw you, I would have taped this up and brought it, you know. Well,
Right.
well, we didn't do that. So now what we have is a little bit of a instability right here, so, and a tear here. So I'm going to use this, a little way to basically send acoustic waves into the shoulder to try to regenerate. Remember, these acoustic waves push stem cells out of the bone marrow. You know, so after the therapy, you're still going to be getting some healing factors from all the growth, the stem cells in the interstitial fluid.
And it gets oxygen.
Oxygenation, and well, yeah, because remember now, neurovascularization, you got it, man. I remember, I love working with healthcare because you get it. You know, when something's been chronic, we've lost the oxygen. Now we're producing more of a degenerative problem. Why do we degenerate a joint? Loss of oxygenation, you know, and then the body starts to do what? Adapt and then create bones because it's not getting blood flow. So I'm going to get us, it's mechanism of healing, you know, no blood flow. Okay, let's start to close up, you know, so I'm going to get us more blood flow.
Good.
All right, let's go with the flow and get some blood flow.
Let's get some flow.
I thought I was unique when I say we catch the wave like a flow, but it's actually a term. So every time you think you're unique, you're like, oh man, somebody else came up with it already. I'm not too unique. Okay, here we go. So right now, I'm actually in the supraspinatus for you, okay? And you can feel, this is the particular muscle that's torn at the attachment. So I'm gonna work the origin, right? Feels good, doesn't it? Okay, I'm just going to hold it here, and then we're going to follow the muscle all the way to the attachment, okay? Wow, that's levator now, right there.
Oh, right there.
Right there. I'm going to hold it. You can hear it too. You see the vibration changes. Hold it there. Good. Okay, I'm going to bring it up. Good. Right in there. Good. Let's turn the head this way and tuck it down. Hold it right there. Good. So what I want to do here is I want to work all these muscles attaching to the shoulder blade, because whenever we have that instability, what happens is they're working harder or not working at all, and then the attachment's right there. You feel that? That's the rhomboid middle trap. We start to get fibrous adhesions all around the connection of the shoulder muscles that are there for stability. So now,
It amazes me how you find exactly the spot.
Well,
Do you feel it?
oh yeah, well remember now, I'm following the work of other doctors, you know, Vladimir Punjabi, who put together upper cross and lower cross, so, and then a little bit of intuition. But right now I'm working the rhomboid attachment with what they call a continuum distortion. So it's another one of those fascial distortion techniques based on the way the connective tissue distorts.
And it's right there.
Yep, which makes sense because our shoulder blade's not stable, right? So that means these rhomboid muscles are having to do so much work. So they pull you know, a little bit of the osteophytes. Remember the osteophytic particles? Little bony particles get pulled into what they call the transitional zone. So tendons don't just attach to the bone. There's like a little bit of a transitional zone where it's a little bit more fluid even. And then that's where that's where I need to push into the bone and knead those little particles back into that bone where it was being pulled from the attachment.
Wow.
Right there. Good.
Yeah, you're right.
Right there. You feel it too, right there, Rob?
Oh, perfect.
So this is all the stabilizing muscles. So since they basically are getting pulled so much, it's pulling a little bit of the bony particles into that transitional zone. So what you felt me doing was knead them back in. Felt good though, didn't it?
Oh, yeah.
Kind of a good bad.
Yeah. No, it's a good.
Good, good. Oh, I love it. Oh, yeah, and you could see that. This is the bottom right there. And I could tell, yep, we have, and you can see it's elevating a little. I'm gonna do a little bit of work on the bottom of the scapula too. And then we'll probably do a little bit of release to the active release to the supraspinatus. If we can, we'll see. We'll test it. There we go, I could hear the vibration. That was 16 hertz, I like 15. That's the bottom. There we go. Now I just want to get right in. God. Actually, you know what I'm going to do too for you. So since what happens here a lot of the times is our shoulder's been a little unstable going this way, we've produced some adhesions in that back. So I'm going to come through and loosen them.
Wow.
Good. Can we put this arm behind the back like so? Okay, good. That's not horrible. I'm going to support here and then just come in. Good. Breathe with this belly again. There you go. Breathe. Good. Good. Good.
I felt it release.
Oh, yeah, you felt that. Me too. It was good. So what happens are people don't really remember, but the shoulder blade's a joint. You know, it's called the scapular thoracic joint. It's supposed to be stable, where it really doesn't go up and out. So our scapular thoracic joint's not stable. So underneath, we're producing some fibrous adhesions. So in fact, let me put the arm behind, and since I got the tool, let me grab this tool for us. Since I felt it, let's get in there with our arthrostem. They use this a lot for ribs too, but let me come in through here and support. You got you.
Wow.
Let's get in there, use that percussion underneath that scapula and really start to break up some of those adhesions because the body's been adapting. And angle it a little bit different. Angle it. Good. Careful coming back over. Good. How'd that feel, Ruff?
Awesome.
Good. Okay. Let's come over. Good. All right. Now, let's see this arm. Ralph, do me a favor. Lift that arm all the way up as high as you can. A little better than it was. You're still kind of going to the front to use the deltoid, so let's come back down over to here. Good. Slowly lower it for me. Good. So you have control, which is really good. Felt a little bit of hitching. You felt that, right? It wasn't as smooth.
No.
So we still have a little partial tearing in here, right?
Yeah.
Let's see if we have a good muscle strength. Ready? I want you to hold the arm up. I'm going to push towards the ground. Hold it up. Okay. Hold it up. Any pain or just weakness?
No, I have the pain.
Pain and weakness?
Yeah.
Okay, let's see if we can correct that. Hold the arm up there. When I ask you to, I want you to bring your arm behind your back like we did, right? All right, good. So I want you to hold the arm up. Okay, slowly bring that arm back. Good. Bend that elbow. Good, good, good. Now we're going to hold it in this position. You know me with my belly breathing. Start your belly breathing. Natural belly breathing. Just natural. There you go. Natural belly breathing. This gets us oxygen to these muscles. It also gets us to loosen all of these accessory and chest muscles. Good. Good. Let's bring it back up slowly. Good. Let's do another maneuver. Okay, right there. Okay, slowly bring that arm back. Good. 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 Now belly breathe. We're going to hold this position. Give your body time to allow that to lengthen. Good. Now, let's bring that back up. All right. I want you to test that one more time. So I'm going to hold there. I'm going to push down. I want you to hold. Got the strength back.
Oh, yeah.
Was there any pain that time? A little bit?
Yeah.
Point to where you felt the pain still. At the attachment? At the back. Posterior. Right in there.
Yeah, posterior.
Posterior. Well, let's see here. Okay, so I want you to bring the arm up. Okay. Any pain when I bring it up like that?
Not too bad.
Good. Good. Okay, good. Now what we're going to do, I'm going to let my thumb go. Now I want you to bring it up again.
Okay.
Less or more pain or no different?
It's a little less, actually.
A little less. Okay, good. I think the bursa might be a little involved there. So let's actually go into the subdeltoid bursa and give it a little bit of, remember, I don't think it had bursitis on the MRI, but it could still be a little irritated. So let's get in there. Right in there, right? What I'm going to do too is when we have our providers and our doctors doing the injections, usually they come in posterior, right there. And then now this is getting internally into that joint. So I'm going to hold it here so that I can send that acoustic wave into the joint where we have degeneration. Because remember, what are we creating? Oxygenation. Good. Okay, let's do. Okay, good, good. Can you bring the arm up? I can feel it clicking a little. Good. Bring it down. Good. Good. Let's go this way. Any pain? Go there. All right, so what I want to do is a little capsule work, okay? So we're going to start here. And then when I ask you to, you're going to bring your arm up like that. All right, so we're going to start there. Okay, bring up that arm. Good. Let's bring it back down. Okay. Bring that arm back up. Good. Nice. Bring that down. Good.
What's that doing?
So I'm working the capsule. So when you're bringing it over, you felt the counter force going this way. So we're basically remember now a frozen shoulder is what? Adhesive capsulitis. So that's when the capsule gets inflamed, and then the inflammation, remember what we said, inflammation creates what? Fibrotic buildup. Actually, it's fibroblastic activity. Fibrogen gets produced, and then all of a sudden you end up with an adhesive capsulitis. So it adheres. So that's the term, frozen shoulder. You know, so I don't want that to happen. So what we did there is we just started working a little bit of the capsule so we don't have that happen. And now let's see, I'm going to bring the arm up. Now I want you to hold that arm up. I'm going to push down.
Okay.
Wow, we got strength.
It's back.
Yeah, strength is back. How did the pain? Still there a little?
Not really.
Not too much. Good. So we got a little bit of the capsule inflaming a little. So what I did is I sent some sound acoustic waves into the joint itself,
Right.
and then we did a technique, like a myofascial technique, to free the connective tissue from the capsule. The capsule is every joint has the capsules where all the tendons connect to. So now if we have a all the tendons are like, they're connecting into this capsule and it's froze, the tendons are basically can't activate, so it's just it's a frozen shoulder.
Right.
You know, so I don't want that happening, so that's why we're going to do that work right there.
Awesome.
Good. Okay. Right here. I'm going to do some work in this area because you could see your head going forward. This is the joints that take a lot of the forces, and then up at the top. So let's work this area and get you feel a little better. Okay.
I feel better already.
Oh, I love hearing that. Okay, good. All right, so now what we're going to do is let's just get right in here. And I like symmetry, you know, so the fact that I did a lot of the upper back and upper body here, I don't want to leave it so I don't do anything on this side. Yeah, you can feel that too, right in that super. You can hear it. It's needed. Good. Right there. Good. Right there. Good. Okay, now. Move that one there. All right. Okay, I'm going to leave a little bit there so that I don't give you any type of burn, but I can let my finger glide.
You're right on it.
We're going to bring that head up, bring that arm up. Remember, when I ask you, I just want you to bring that arm over like so, and then we're going to turn our head and tuck it towards that knee, okay? All right, we're going to bring the head back and up, good. All right, bring that arm down and the neck, there you go, good. Good, breathe with the belly. Good job. Okay, come on over to this side. Okay, we do the same thing. Bring that arm up, bring that head over, bring it there. Okay, go ahead and move that. There you go. Good. All right. Now, let me see. This is the good shoulder. So let's use this shoulder.
Okay.
Keep it straight like this. I want you to, I'm going to push down just a little. Good. So that's my indicator. I'm just muscle testing, right? And I'm not looking to overpower you, just seeing whether this muscle activates, you know? Now what I want to do is I'm going to bring your head into certain positions and see if we get a muscle weakness. If we do, I can correlate what region based on the movement, all right?
Okay.
So what I want us to start with is just turn your head to that side, hold the arm up. Good. Turn your head to this side, hold the arm up. Good. Let's bring your head back to the center. Let's tuck your head all the way down. Hold the arm up. There's our weakness. Okay, so keep it there. I'm going to put pressure. Hold. Good. Hold. Okay, so we got a C-set. So what I did is kind of cool, huh? You know, so I'm basically using your body, and then when you go into flexion, most of that is all done in the lower cervical. So I now know that there's a problem in that lower cervical, and then I kind of tested it by challenging, putting pressure. And then I noticed that when I went here, it didn't do anything. When I went there, it did. So I'm going to come back and I'll do a little manipulation. Okay. So have you just relax. Good. Right there. There it is. Good. You okay, buddy?
Wow, great.
All right, let's retest that. Come on over. Hold that arm up. Okay. Tuck the head down. Hold it up. cool. It blows my mind every time. Good.
Wow.
Now I want you to take your chin and I want you to just tuck it in, just like this. Ready?
Okay.
A little bit higher, like that. Perfect. Hold. Good. That was Atlas. Now do me a favor, just bring your head back. Good. Hold the arm. Good. So we just had relax. Makes sense. You relax the head. So it makes sense. That's why I love letting your body tell me. You just had a subluxation, a fixation at the lower part of the cervicals. And it makes sense based on the anatomy, because when we have this forward posture, our head goes forward. So we either lock up here or lock up on the bottom. So you were locked up on the bottom.
Wow.
So we got that.
But I don't feel it anymore.
No, it feels good, doesn't it?
Yeah.
Beautiful.
Wow.
All right, let's see. Turn your head to that side now. A lot better. Turn over to this side. A heck of a lot better. All right. That was awesome. How you feel, man? Pretty good?
You're amazing.
Thank you, man. You should have that on camera.
Oh, yeah.
By the way, he said I was amazing.
Yeah.
Oh, man. So let's do this. I wanted to work also on your significant other, right? So,
great.
All right, perfect. We'll get that
Ruth
ready.
has been,
Ruth's basically neck, upper back.
Her back, her shoulders, her
Well,
neck.
most of it's all usually going to be, again, the same problem, you know? So let's do a quick
Ruth
assessment.
speaks Spanish.
Ok, yo hablo español también, entonces...
Muy bien.
Entonces...
I thought you needed my green-
No, no, está bien, vamos a hablar en
my bad
español.
accent, my bad Spanish.
Ok, vamos. ¿Dónde tienes dolor ahora? ¿En qué parte?
Wow, I can put my shirt on without...
Wait, look at this, amazing, I love it.
Oh.
¿En qué parte tienes?
Acá en esta.
En los dos, ¿verdad?
Sí.
¿Y qué? ¿Y en el centro?
Sí.
Okay, ¿o en los lados?
No, en
En el centro. ¿Y qué haces para trabajo?
Fuerza.
Fuerzas con las manos,
Ujú,
limpiar,
mucho.
muchos, ¿verdad? Ok. ¿Duele un poco
No.
ahí? Ok, Did you name it? Yeah, come on, you get there. Awesome. Oh my gosh. Hold on. Hold on. Our family medicine practitioner needs something. The blanket. Oh, even more important.
Oh, yeah.
Probably a patient needs it.